Sorry, David, we're not hearing you, David.
There we go. I think I put myself on mute on my headset and not my desktop, laptop there. Yes, we received apologies from Andrew Murray, Victoria McRae and Roger Ridley. Patricia's introducing an equality session for our newly elected members at 9:30, so she's going to try and join us as soon as she can. That's fine. Okay, folks, I've not seen you all on the screen, so I'll try and, be aware of hands popping up and all the rest of it, but clearly if I miss anyone who's wanting to say anything, just shout out. We'll crack on. Any declarations of interest, either in general or anything specific to any of the items on today's agenda? No? Excellent. So if we just reflect on the minute of the last meeting, which was the 25th of February, I'm not intending going through every page, but hopefully you've read them. Any amendments, anything we haven't got right that we need to change? Ellen, you've got your hand up.
Yes, I'd submitted my apologies for that meeting.
Okay, Ellen, thank you. We will get that noted. Thank you very much.
Stephen, I think I had as well, actually. Sorry, it's Linda Benny.
Hi, Linda. Okay, yeah, so we could just make a note of that both Linda and Ellen had noted their apologies for that. Anything else? Are we happy to approve those minutes? Yes, thank you. If we move on to the action log, if I'm right, we've got two outstanding actions. The first two, the presentation of medical assisted treatment standards, and that's not due until July of this year. There is an update with regards to that. The second is the hospital acquired infection performance report, and that's June 2022, with an update for that as well, but we'll come back to those two in future months. And the other two actions are closed. Is that right, David? I think there's nothing else. Nope.
No, that's right, Chair.
Thank you very much. So if we move on to item 5, and that's the suicide drug prevention report that is going to be delivered by, is it Elaine?
It is, Stephen.
Thanks, Elaine. The floor is yours.
Thanks, Stephen. Good morning, everybody. And the purpose of today's report is to update committee as to the work currently being progressed in relation to suicide and drug death prevention. And committee is asked to consider and comment on the contents of the report this morning. Just in terms of a quick summary of the content, so in the latter half of last year, there was a commitment and an investment to the suicide and drug death agenda. So through NHS Forth Valley Public Health Resource and funding awarded to the Alcohol and Drug Partnership, myself and my colleague were employed to further support the local approach. Our work is closely aligned to that of the Falkirk ADP, and Martin's on the call today, the Mental Health Planning Group and the IJB itself. As members are aware, both suicide and drug death have been declared public health emergencies in Scotland, and therefore a whole system approach which considers all the determinants of well-being is essential to address what is often a complex interface of risk factors. In this role, I've been asked to focus on 3 key areas, and although there's many subsections to them, they can be summarised as, sorry, I've got a cold this morning, so you'll need to excuse me, to oversee and develop the expansion of the DRD and suicide review processes, to develop the Forth Valley Prevention Strategy, and to establish a senior prevention partnership, which will be chaired by the Director of Public Health. Before I briefly explain the key tasks that we're taking forward, the data is highlighted within the report in terms of the last published data. In relation to drug-related deaths in 2020, there were 77 deaths across Forth Valley, and the local authority breakdown is contained within the paper. And in relation to suicide, we sadly had 43 completed suicides in 2020, and again the local authority breakdown is in the paper. There's much focus on the data, as people on the call will know, and while it's important that we understand our numbers, we need to remember that each one represents a person who had a story, and a family and friends who are left behind as well. In terms of the review processes that we're developing in relation to drug-related death, to summarise the main changes, we are now considering all drug-related deaths in one process. We have split them into a geographical model, so we have one meeting for Falkirk and one meeting for Clackmannshire and Stirling. And we've consolidated the multi-agency approach, so the paper lists the wide range of partners who are involved in that drug-related death review process. And that's essential for really taking forward that public health approach that I spoke at the start. Item 4.11 in your paper lists some of the themes that we've identified to date. Moving forward, alcohol deaths will also be included in this process. So if you look at the last published report, that would have been just over 70 deaths that were classed as alcohol deaths being brought into that process as well. In relation to suicide, to date the cases that are reviewed are those who were known to statutory mental health services or substance use services in the 12 months before their death. That we recognise that that would have been less than half of the 2020 deaths, so we will develop that process to ensure that we review all probable deaths by suicide across Forth Valley, and that will take a multi-agency nature in the same kind of vein as the drug-related death ones. We have enhanced the process so far, and what we have at the moment is the police are notifying us of all probable suicide deaths, even if they weren't known to service. And at the moment, that importantly is allowing us to monitor trends and potentially identify locations of concern. We hope to agree the expansion to the suicide review model by the end of 2022. The engagement process to develop the Forth Valley Prevention Plan, hopefully most people have seen that via various channels. So the engagement process is now live and will go through to the start of July. We released a survey last week specifically in relation to suicide prevention, and we've had 166 responses as of yesterday to that, which we're really pleased about. We'll also support that with 6 facilitated engagement sessions, and again the dates have been circulated, but if anybody needs them we can send them again following the meeting. In relation to drug-related death, we've held a number of workshops already, including with ADP members, with people with lived experience, and we're also planning one with family members as well. Those affected by drug-related deaths and suicide can be a huge voice for change, so it's really important that we listen to what our family members and those affected are telling us. The output from all of these strands that I've highlighted, plus the learning from the reviews, will support the identification of priorities that will not only support collaborative Forth Valley activity, but importantly potentially allow us to target work in the local authorities depending on identified needs. From a governance perspective, we need to ensure we have a strong quality focus and monitor progress and the direct correlation to the performance framework which will accompany the prevention plan. So in summary, significant work continues to support the expansion of the review process. We have a programme of engagement activity underway. Partners are invited to fully participate in the engagement process, as well as the implementation of the prevention plan. To finish, collaboration and partnership approach is absolutely critical to the success of the forthcoming prevention plan. I'm happy to answer any questions on the report, Stephen.
Elaine, thanks for that. I don't have any questions, and I'll open it up in a minute, but for me, obviously, deaths from suicide and alcohol remain far too high, not only within Falkirk, but across Scotland. So delighted to see the additional 2 posts and much more integration across this. I know we had a long chat till end of last year in relation to that, and it's good to see the plan being developed. So hopefully we can start to see a reduction in these figures going forward, because they are too high. And I think your point, there's a story behind every one of them, sadly, and it's a very sad story, and the impact it has not only on the immediate family but friends as well, and across all our services. So yeah, I'm delighted to see the progress there, but I will open it up for any questions or observations for Elaine. David, and then Sarah, and so start with David.
May as well say something, seeing as no one put their hand up, Elaine. I think it's a really good report, Elaine. I think actually, unfortunately, I suspect the numbers are going to go up in the next couple of years, judging by what we are seeing sort of day to day. There's a lot of problems with mental health in our communities and a lot of problems with poverty, etc. It's really important that we really focus on mental health and well-being for more than just drug takers and more than just people that are feeling suicidal. We've got to improve overall mental health and well-being to actually reduce the number of people turning to drugs and turning to suicide. So, you know, hopefully we do have some pieces of work going on for that, and hopefully some of these initiatives will actually help. So putting link workers and mental health workers into GP practices and the third sector mental health fund will hopefully sort of provide some of the stuff that will generally improve the well-being of our communities. So yeah, it's a sad story, isn't it? But even if we do a great job, the numbers will probably go up. At the moment, you know, that doesn't mean we've done a bad job necessarily, is just what I'm thinking.
Yeah.
Thanks.
I agree with your points, David, and I suppose that's where the benefit of looking at it through a public health lens comes in, and we do look at a kind of whole population approach, and that includes the point that you say in terms of improving general health and well-being. And the golden ticket is to stop people ever starting in the first place in terms of substance, but that requires us to address poverty and inequality, childhood experiences, etc. So again, that's where the links to community planning are really important, and looking at that wider community interface as well. I think the point that you touch on in terms of numbers, it becomes a little bit of a rabbit hole, and that's one of the main challenges we'll have in terms of developing the performance framework, because it has to be about more than the numbers. And as you say, progress can't only be determined by the number, although that's really important. We need to look at other things that help us measure progress and success. So that's a challenge that we've not quite addressed yet, or found a solution to, I should say.
Thanks for that point, David. Yeah, you know, that there's a whole wider integration, but you're right, across the whole of our mental health landscape. Sarah, you wanted to make a comment?
Yeah, thank you. Thanks, Stephen. Hi, Elaine. I don't think we've met before. I'm Sarah Lacey. I'm Head of Children's Services Social Work and the Chief Social Work Officer for Falkirk. Thank you very much for the report, and it's really good to see the planning that is in action. I just wanted to ask about, I mean, sadly, young people are often feeling suicidal, and, you know, will occasionally complete suicide. I wondered what consideration there is within the planning, just really kind of following on from others' comments about the kind of full scope and the lifespan of young people and existence within families and these persistent mental health issues. The scope of the planning of the work that you're doing, does that include young people?
It will do, Sarah, yes. So the prevention plan will look across the lifespan, and I suppose that fits into the point that David said in terms of how do we equip our children and young people to be more mentally resilient and to be aware of the mental health. And I suppose it ties into developing a compassionate community, I suppose, as well, where people can say when they're struggling. And the best case scenario would be for people to not require secondary care and secondary care mental health services, and that we can develop community resources that can support people's general mental well-being before it kind of becomes a mental health concern. So Jill Campbell's closely linked into some of the work, Sarah, in terms of some of the developments for children and young people. And we're also talking about maybe doing an additional session for maybe pastoral heads in terms of including them in the planning for the prevention plan as well. So Jill has recently invited me to sit on the children's planning group as well. So we'll connect all of that through that.
Wonderful. Thank you very much, Elaine.
Again, just a good example of widening it out and integration, and an important point to try and intervene as early as possible. Two other hands, I've got Elaine and then Gordon.
Thank you, Chair. Hello, Elaine. I'm Elaine. I don't think we've met either. I'm Elaine Kettings, and I'm the Chief Nurse for the Falkirk Health and Social Care Partnership. Good morning. I really enjoyed your report because it's got people at the absolute heart of it, Elaine, and that really stood out to me. Just a couple of kind of positive comments, if that's okay. So my first thing I really liked in your report that you've linked it to the IJB strategic priorities. I think that's really important for the context at the meeting that we're at today. So I really liked that. I suppose my second thing is that I'm really pleased to see that there's been investment in your service. And sometimes it's always, people think investment should always be at the front line, you know, that interface. But sometimes making investments in other areas can really, really improve outcomes for people. So I was really pleased to note that there's been investment in your death review team. Because to me that's sometimes a forgotten area where, you know, we've got so much work to do with too little people, and that's a really learning rich environment if we've got the time and the people to do those death reviews and do them really, really well, because that's where we'll get the key learning. And I can see that you've mapped that to a development of your prevention plan, so I think that was that really stood out to me. And my third thing is just a suggestion of the spiritual care team who support Forth Valley in a whole, just to link in with them. I think they would be very strong in that space in terms of that, that they're very connected with the bereavement side when there's been a suicide. So I think getting them up the front in the prevention plan as well would be a really smart move. Thank you.
Thanks, Elaine. We've connected with the spiritual team in terms of the police resource that goes out following, particularly a suicide death. What we do recognise that there is a gap in terms of kind of bespoke bereavement support for families who are affected by suicide, because the grieving process can often be a little bit different, just in terms of predominantly the stigma that families face around that as well. So we have connected to them. I think we need to continue to do so, and as you say, have something very specific within the prevention plan. A key area that was actually even in the job description for the post that I now have was to look at how we further develop that bereavement support for families as well. We know that it increases people's own risk of future suicide as well, so it's definitely a key area for further development.
Yeah, and there's a big bit of work going on in spiritual care around bereavement, so it's just connecting into that, and there's folks that you'll know in that space, and it'll just all join up together. Thanks, Elaine. Lovely meeting you. Thanks for your report.
Thank you.
Elaine, thanks for those positive comments. We do like positivity and some of those suggestions there. Gordon, you've got a comment to make.
Thank you. It was to echo what David and Sarah had been saying there about, sorry, I'm Gordon McKenzie, I'm one of the locality managers within the partnership. It was to echo some of the comments there made by David and Sarah. The locality social work teams are feeding back to us that they are seeing a lot more people presenting or referred to them with poor mental health, with suicidal ideation, with self-harm. A lot of younger people among that, Sarah, and those are coming through as adult support protection concerns, which is driving a lot of activity within the social work community care teams. So there's quite a substantial effect across the different parts of the health and social care sector. I'm sure GP practices are seeing a lot of this. We're seeing it in social work as well, and we need to work together to try and find better ways to engage, because one of the things that the social work teams are report to us is that while they're getting a lot of referrals, they're not getting the engagement when they're following that up, and we need to get better at what we're doing to improve that and to get to people early and help them to move on a safer path for dealing with their mental health issues. Thank you.
Yeah, thanks, Gordon. I think it would be really good if your staff could kind of participate in the engagement process as well, and really feed in that real-time information in terms of what they're seeing at the coalface, I guess, and that helps us, you know, kind of mark that in the sand in terms of when we're looking at priorities. The other bit, just to mention in terms of a bit more of an innovative and a different approach that we're taking at the moment, is there will shortly be a non-fatal overdose response team coming online who will assertively outreach to people who have suffered a non or a near fatal overdose, and really importantly there will be recovery workers attached to that team. So just picking up on your point in terms of the engagement after these situations is sometimes not great, whereas recovery workers can maybe take a bit of a different approach than we can as services. So we are looking at how we can offer different routes into service and kind of different opportunities for engagement as well. So we'll make sure that that is widely promoted to the social work teams as well, so that they can link in with that. Gemma, Richie and Grace Carey are really supporting the review process as well. And I think the second part to that is we need to make sure we're sharing the learning with staff. so that they're understanding what we're seeing and importantly what we're doing about it as well. So we've not quite connected that dot yet, so any support from yourself in terms of how we share that learning with frontline staff would be really welcomed in terms of any ideas you've got.
Yeah, I think that's a valid point, Elaine, about, you know, how do we, I suppose, downstream this a little bit to those at the front end. So again, I suppose any suggestions or they can do there, you know, feed into Elaine. So thanks for that. Thanks for that paper, Elaine. That prompted a lot of good discussion there, and a good paper, and good to see progress in what is clearly a very difficult area. Anything else? Any other comments, observations, or questions for Elaine? Okay, we'll move on to 6, which is the HSCP Locality Working Progress Support. Is that Gordon or Martin that's doing that? Is it Gordon, you doing that? Right, Gordon, over to you.
Thank you very much, Chair. So quite a wide-ranging report here on some of the work that's been going on across localities in Falkirk. We've been trying to develop a locality model of working in Falkirk for last 2 to 3 years. COVID has somewhat interrupted that, and but we have been making progress. And within the report, you can see a number of examples there of the sort of things that we are doing and doing well. 4.8 talks about the Back to Basics pilot that there is in West Locality, talking about bringing together staff from across the partnership to look at specific individuals or situations where by working together we feel we can provide a better service. That's not to say that that sort of work wasn't going on in the past, but what we're doing with the locality model is we're embedding that approach and developing it, and we're going to roll it out across the other 2 localities now that we've kind of proved how to do that. Within the report, there are a number of other examples of how internally within the partnership we are changing the way that we work to provide more of a locality focus, locality approach to the services that we deliver. Later in the report, 425, the report talks about locality community work. This is the other big area alongside how we work internally, I suppose, how we work with the communities, alongside the communities, and co-produce with the communities better services, better responses to the needs of those communities. Again, the pandemic has had an impact on the progress we've been looking to make with that, but there still are positive stories there about how locality work community work with the third sector in particular has delivered better outcomes for people in our localities. One of the points I would highlight from that, although there is that very positive message there, the COVID pandemic has had an impact on volunteers. We have seen in a number of areas, the number of volunteers drop away. So we're looking at ways to support volunteers better, to try and support the third sector to recruit more volunteers and get these services, get these voluntary groups back up and running. Quite a number are, obviously, and some have never stopped throughout the pandemic, but there's no doubt there has been an impact on some services. So, as I say, a wide-ranging report. I'm happy to answer any questions. I'm not going to take credit for all the good work that's in there. Winston MacArthur, our partnership manager, has dealt extensively with the third sector, and my colleagues, the other locality managers, have been involved in many of those projects as well. But happy to take questions.
Thank you, Gordon. Yeah, lots going on, and again, it's a difficult environment at the moment as well for people to operate in post-COVID. Well, still a bit of COVID about, clearly, but you know, that recovery is really tricky. So thanks for that. I'm not seeing any hands up. Have we got any questions for Gordon? One's going to, oh, Margot, yes. Thank goodness for you, Margot.
Oops.
Margot, you're
right. I'm fine.
Yeah,
I've managed to unmute. It was really the whole section on the community link workers and to commend what's sort of being done there, and to just really stress its importance, and to see how important, you know, as regards this report's concerned, you feel it to be.
Absolutely, Margaret. Thank you for the question. I did want to highlight the two areas, the two big parts of locality working from the partnership point of view. There's that almost inward-looking part of, you know, how we organise the services that we actually deliver. But the bigger part of that is how we engage with the communities and how we enable communities to engage with us. And the link workers are a major part of that. They know a lot about what's going on in the individual communities. They're able to engage with people, identify and help to identify needs, support people in those communities to articulate needs. And that's what's going to drive changes over the next year, 3 years, 5 years across those communities, the services that we provide currently, and the changes that we need to make in those services, and new services that we need to develop. It's also part of, you know, getting there earlier. A lot of the services that we provide are there for people towards the end of their health and social care journey. I don't mean to sound fatalistic or anything about that, but, you know, when things have gone from bad to worse, shall we say, by working with local communities, we can intervene earlier. We can empower people to manage their own conditions. That's a key strategic aim for the partnership. We don't have a massive pot of money, never-ending money to throw at, or indeed staff to throw at the issues that we face. We've got to enable people and communities to help to manage these problems themselves, and they, in many cases, know best how to do that. So a very big part of our work, and thank you for the question.
Thank you.
Yes, thanks for that, and thanks for that report, Gordon. Any other comments, questions, observations for Gordon? No? Fine, we'll move on to 7, which is the Forth Valley Quality Strategy. And Susan, are you going to cover this for us?
I am, thanks, Stephen. And can I say thank you to you and the committee for inviting me and giving the opportunity to talk about the quality strategy. It's a great opportunity, and the quality strategy was presented to the 2-year strategic management team earlier in the year. So I'll just head out. Everybody has the paper and the full strategy there, and you may or may not have read the full strategy, but I'm going to take you through a summary of what's in there, and really stressing to a bit of how we're taking this forward in terms of implementation, because it's all fine and well, as everybody knows, around the table having a strategy written on paper, but implementing it is really where it has to come alive, and we need to involve as many people as possible in that. So having the quality strategy is obviously a key element of responding to all of the challenges that we've got coming out of the pandemic, and those are well known to everybody. So the quality strategy for Forth Valley NHS was developed over a period of about a year, and there were members and representation from the Falkirk Health and Social Care Partnership who kindly and gladly joined us in developing a kind of direction for the quality strategy, and have been with us throughout some of the implementation. So the committee this morning is asked to note the strategy that was approved last June by NHS Forth Valley, and to note the implementation of the approaches and elements of the strategy, and how that particularly contributes to strengthening clinical and care governance and assuring standards of care, which is of importance to this committee. The quality strategy itself has a key vision, which is outlined there in the strategy, which is to improve the experiences of health and care for the people of Forth Valley by working together to deliver quality care and support that is recognisable and meaningful. And I think that those last words are particularly important, that it needs to be meaningful and it needs to be able to be recognised. The foundations of the strategy would be well known to yourselves: national health and wellbeing outcomes, and better health, better value, better experience, and better delivery of care. The scope of the strategy, as was determined at the very beginning of setting out on this, was for NHS Forth Valley, right across NHS Forth Valley, and the services integrated within the health and social care partnerships, which I think was great to have that collaboration and to be going ahead in that way right from the very start. There are 10 guiding principles, which I'll not go into, but 5 of those were chosen for the initial priorities for implementation for across the first year. And those are involving patient service users and carers, which I'll talk a little bit more about, working as a system, focusing on relationships and culture, having consistent and coherent approaches to improving quality, and using data effectively. And so you'll see that those 5 priority areas will really help us build the conditions for change across the whole of the system. The strategy also gives an idea of how success might be measured for each of the 5 priorities. So there are statements contained in there. But I think the key point to make here is that we're intending for and we're taking the strategy forward as a living document. So we review and we revise it as we go on. So as part of the implementation, those success criteria will be reviewed and might be updated or revised depending on how the work goes. So the strategy has at its core a quality management system. So basically that means effectively managing for quality. So setting the conditions in place. So managing quality really well, planning for quality. It starts really with planning for quality. What data do we have? What information do we have to build on and to go and improve upon? A central part is how we control and assure quality and standards of care. And I'll talk a little bit more about that. And then how we actually go about what approaches we use to improving quality and who we involve. So what particularly in relation to clinical and care governance, we're exploring in the strategy the extent to which having a consistent and strategic approach to clinical and care governance can be achieved. So we're really looking to see what is it that can be done consistently across NHS Forth Valley and our health and social care partnerships, and what is it that needs to obviously be done and led and driven by the partnerships themselves and the IJB. And within the quality strategy, we set out to have a clinical governance strategic implementation plan and a toolkit, which are both in development. Moving on, realistic medicine is integrated within the strategy, and that the realistic medicine action plan includes actions to support staff across NHS Forth Valley and health and social care staff across partnerships and integrated services. And we've had some really helpful conversations recently about realistic medicine and how we take that forward to benefit a wider group of staff and patients and service users, families and carers. And finally, probably importantly, in terms of the content of the strategy, is we set out our return on investment approach and how that will be taken forward. So to conclude, because there is a lot of information in the strategy, there's a lot to take in, but one of the key priorities, as I said at the beginning, was to involve service users, carers and patients and families proactively in taking forward quality improvement work. And this is one way, obviously, of making this feel really tangible. And practically, as part of the implementation, that's already been taken forward in some ways. We have a quality improvement toolkit set of tools and resources, and they've been made available on the NHS Forth Valley extranet on the web, so that anybody can access those. So those can be accessed by staff across health and social care, but also importantly, by people who use our services and their families and carers. And we really want to build on this significantly across this year. So the quality strategy, really the purpose of it is to empower and support staff to do the right things and to do them well, and to make sure that we have the right controls and assurance in place to make sure that we're doing those things really safely and effectively. What it does need is for us to invest and prioritise time and allow and enable staff to be able to invest time in both planning for quality and for safety and assurance, and not least for quality improvement. And so we did take an organisational change case forward, which was supported, which means that there's a little bit more central support to help staff to do that. And we're investing in quality, what we're calling quality internships, which is really an opportunity for staff to have more experience embedded within Forth Valley Quality, and then to take that out into their day-to-day work. So implementation of the strategy, as I've said, we're really trying to involve as many people as possible in that, and really welcome any ways of doing that that people want to highlight. But the strategy implementation should contribute to delivery of the partnership's strategic outcomes, particularly in relation to safe delivery of high quality health and social care services, and to make sure that people have a fair and positive experience, and that staff particularly are well supported to gain the skills to take this forward. So I'm going to stop there. I hope that's been enough information for us to have some discussion or questions, and I'm happy to take those. So thank you.
Thank you, Susan, for bringing that Forth Valley NHS strategy to this committee. Obviously, I know a little bit about it. I like it. I think that graphic under 4.5 really speaks volumes to what you're trying to do, and I'm delighted that the kind of principles of realistic medicine are integrated within it, because we were really pushing realistic medicine, I think, prior to COVID, and then we had to pedal full pelt during COVID, just trying to keep you up, and it seems to have dropped a little bit off the agenda. So thanks for that. Patricia, welcome, and I see you've got your hand up and you want to ask a question, so yes, over to you.
Thank you, Stephen. Apologies, colleagues, I had to do a session for the council this morning before I came on. Really interested and welcome seeing the paper at this meeting. I suppose for me, we're developing thinking. I see Elaine's got her hand up as well. You know, building on the care home assurance teams that we've had through the pandemic, and also, you know, the infection prevention and control, but also really I want to look at how we can develop that quality improvement, quality assurance capacity in our services, so that we're not waiting for a care inspection report to find out that there's issues emerging in care homes. So it's really building on what we've done during the pandemic, but bringing in that more robust QI, quality assurance, which I think sits under this quality strategy, and really would welcome some support. I know Gail and Elaine and others are already having conversations about this, but it would be helpful to have some of that quality support from your team, Susan, if that could be made available. Thanks.
Thanks, Patricia, for that. And yes, yeah, recently we've had conversations, Gail and myself, but also previously with Elaine, and we're at the point with the support that we offer of going into 22-23 and developing the plan for that, and we're taking that to the programme, Forth Valley Quality Programme Board next week. So it's really timely to be having the conversation about how we can better support that. We have still a limited capacity, as you know, Patricia, but really keen to have those conversations and to see what can be done, because it may be that there are some kind of quick wins that actually don't need a lot of capacity to help with, but there might be some more significant pieces of work which we could set out on. Suzanne is also on a couple of the groups that we're taking forward the implementation plan with, and one of those is working as a system, and care and clinical governance is a key part of that working as a system implementation group. So Suzanne's already made some of those asks, which is fantastic, and we'll work with Linda, Benny and others to take those forward. So yeah, thanks for that.
Thank you. Elaine, will you want to follow up on some of that discussion?
Thank you, Chair, and thank you, Patricia. Yes, that's what I put my hand up for. Just to, you know, as we move forward, everything we're doing in the partnership, you know, is focused around quality and quality improvement, and it's just making sure that our staff have the right tools and support to do that in the right space. So I'll stop there because I think Patricia said that beautifully. I suppose my second point, Susan, was it's maybe been a wee while since I've been around the kind of quality strategy, but am I right in thinking there was a communication plan that would support it? It would sit aside it. Is that ready for us to see?
Yep, the communication plan's there, and there's a monthly communication which we're working through with Elspeth, who heads up comms, as you know, Elaine. And we can certainly share the existing plan with you. What we've been guided to do is use the existing communications, so use staff briefs and staff news, particularly across NHS Forth Valley. But I'm really keen, you know, if there are communication opportunities that we could take through your own comms, that would be absolutely fantastic. And Caroline Deans and her team is leading the communication plan and the implementation of that. So yeah, happy to contact you. I think
this is a real opportunity for us to be in a true partnership in the comms around the communications.
That would be great. Thanks.
Okay, thank you. David, I think you've got a question to ask.
Sorry, hi there. Yeah, there's chaos going on at my door. I think the Amazon man always seems to turn up right when I want to speak. Yeah, so the quality strategy, I mean, it's a really good one, Susan, and like Stephen, 4.5, you know, everything on there sounds really good. It's interesting, we had a meeting yesterday with about 30 of our GPs, and one of our topics was around recruitment and retention, and recruitment and retention is challenging at the moment. And interestingly, one of the things that we came up with that we felt would really help with recruitment and retention is really visible quality work going on in primary care. You know, we think that will keep GPs here, keep GPs motivated, and make people want to come and work here. So this stuff's really important. Sometimes the quality stuff, I always have a slight niggle that I feel as though it's quite often hospital centric, and we kind of need quality improvement staff working in primary care. You know, if we have quality improvement questions and need support, we tend to go to Leslie Middlemiss, but she isn't actually there for that particular purpose. And we need data support specifically for primary care, which again we're sort of lacking. So quality support and data support, and in there's a bit about celebrating success, which I think is another key part that helps recruitment and retention. If we can celebrate success, primary care, as you know, general practice works as independent contractors, so there is a tendency to work in silos, and often there's really good quality improvement stuff that could do with a little bit of quality improvement support just to produce nicer, better, more rounded reports that could then be really shared more widely. And we talked just earlier about earlier intervention, and this falls under that. If you improve quality in primary care, the hospital care, you know, you catch people at an earlier stage, I think is my point. So yeah, really good quality strategy, but can we please have some focus on primary care and not get too hospital centric when we're talking about clinical stuff? Thank you.
Sure, David, thanks for that. And I know Paul Smith was at the recent quality improvement, primary care quality improvement group. And so that's really a way of us trying to connect better with you than we have had for a while. As you say, Leslie had that role, which was a combined role with primary care implementation planning and improvement planning. So we've been looking at that, and one way we were doing that was to invest in training up people in practices. So as you know, 2 of the practice managers worked with us and then have gone on to other roles, and one of them particularly an improvement role, which is great. But we're keen to do that sort of capacity skills building with the internship type of role, which is like part funded match fund kind of post. So if there's any opportunity to be looking at that, I think that would be a really good way that we could take this work forward and build on where you're at the minute. But absolutely willing and open to come and have conversations, you know, to get really down to practically what it is that would be helpful. We have just put out a knowledge manager post, which is, it's maybe not the most attractive name but for the post, but it's a post that would also support some of that celebrating success, you know, capturing the work and then being able to share that in a way that is really engaging and reaches maybe places that it wouldn't otherwise have done. So if we're successful with that, that would certainly give us a bit more capacity. So yeah, happy to talk those through.
No, good stuff and a valid point. David, thank you. Margot, you wanted to make a comment or ask a question of Susan?
Really, more to commend the approach of patient and service user and carer involvement, and to make sure that it's embedded and that it's used at every stage, from informing, allowing them to contribute to making decisions and to feed back the reactions. And I think the strength of this is that you will cover the base of being able to involve the sort of hard to reach in some ways, because they are in many cases your prime service users. So I think it's a challenge, but I think it's one that's being addressed. And I mean, there's no voice that's more powerful than that of the actual patient or carer. So thank you.
Thanks, Margot, and thank you also to being with us throughout this whole journey. So just to say that at this point, that you've certainly contributed and been involved in a lot of the work that we've brought to get us to this point. So much appreciated. Thank you for that.
Thank you. Patricia, will you want to come back in? Okay. Any other questions for Susan or observations? No. Susan, thanks for attending this committee this morning and presenting that. Very well presented, good strategy and a good conversation had by all. So thank you once again.
Thanks very much. Thank you for that.
Moving on now to agenda item 8, which is the lived experience involvement, which is a report by the Partnership Funding Coordinator for consideration and comment. Sorry folks, who's going to take this for us?
Chair, that's Leslie.
Leslie, sorry, didn't see you in the corner there. Thank you.
Thanks, Chair. And can I just start by saying thank you so much, Margot. Your comments there have introduced this paper beautifully. So thank you very much. And hopefully what I'm about to say does very much align with the Forth Valley quality strategy. So the purpose of this report is to update work that's been ongoing within the partnership to increase representatives with lived experience getting involved in health and social care business. So legislation states that integrated authorities must involve people in health and social care partnership planning and decision-making processes. And locally, as part of the suite of documents that go alongside the strategic plan, we have a participation and engagement plan which sets out how and when we'll involve service users and carers also. Furthermore, in 2021, the independent review of adult social care, the recommendations were published, and they included a very clear statement that a relentless focus on involving people who use service, their families and carers should be taken by partnerships. So Falkirk Health and Social Care Partnership have involved people in various groups and in various settings over the years. So for example, with the IJB, with Falkirk Community Hospital Master Planning groups, with partnership funding groups. But what we're now really keen to do is broaden and extend the scope of that involvement. So as Margot said early on, to really embed that involvement and make sure that we're working with people who haven't traditionally been involved in service service-based discussion. So over the course of the last 6 months, we've been working with the Coalition of Carers, Carers Scotland, SDS Forth Valley, Inclusion Scotland and the Carers Centre to design and deliver a range of information and training sessions in the first instance for service users, supported people and carers. So during the course of April and May, we delivered 3 sessions which involved all of the partners being involved and coming in with bringing their expertise into those sessions. And the sort of topics that we covered included policy and rights-based approaches. We had a discussion with the current reps, which was really fantastic. We had a focused information and question and answer session about the Health and Social Care Partnership, which I'm really grateful to Patricia and Suzanne for attending that. And the final session was really about the practical skills and some reflective discussion about how to get part, how to take part, and what people should be aware of when they take part. So we had 9 people participating throughout the 3 sessions, and that was a mix of supported people, service users and carers as well. So it was really well attended, and the 9 people stayed with us throughout the 3 sessions and have also expressed an interest to continue to be involved. So we're now in the process of following up with each of those and having individual conversations about where their interest lies, what type of involvement they would like to have. So, for example, would it be as part of a forum or consultation process, or would it be part of a design or decision-making process? So quite different opportunities available to people, just in line with how they want to be involved. So in parallel to that work, we've started to develop training for staff as well. And the focus of this training won't just be around about the importance of engagement, but actually on the practical skills and considerations that staff should take to make sure that meetings are both inclusive and accessible to service users and carers. Because we recognise that that's not always a skill that is easy for staff. We have a lot of jargon, we have very complex information, and sometimes it's, we just need to make sure that we are being as accessible as possible. In terms of ongoing and future developments, we've started to look at mechanisms for feedback. So we obviously have Care Options at the moment, which is an online platform and mainly focused around NHS provision that offers patients the opportunity to provide feedback on the care and support that they've received. And what we want to do is extend that type of mechanism into social care as well, but go beyond the traditional service user feedback survey that's issued by the staff who have provided the care. And we're looking at opportunities to involve third sector organisations and also volunteers in actually facilitating some of that face-to-face feedback. So in conclusion, the Health and Social Care Partnership have been working really effectively with a range of partners and staff to enhance support to people, service user and carer involvement. The work very much aligns with national and local strategy, and as was mentioned in the previous presentation, with the Forth Valley Quality Strategy. So Clinical Care and Governance Committee members are asked to note the progress and provide any comments, and I'm happy to take any questions. Thank you very much.
Thanks, Leslie. A really valuable bit of work there. If we get any questions or observations for Leslie. Margaret, I see your hand's up. Is that a legacy hand, or have you got a comment? Oh, it's shot down. It's back up. Margaret, have you got a comment to make? Margot, you're muted, so I see Elaine's hands up. Elaine, do you want to make a comment?
Sorry, Ellen. Yeah, myself. Thank you. Thank you, Chair.
I put my glasses off there. I could just see that you put them back on.
Don't worry. So thank you for that. Thank you so much, Leslie. I think it's really, really important in terms of that sense of direction, and it's just really, really worthwhile that I think you're exploring care opinion in terms of that feedback. We've seen a growing use of it across Forth Valley, and it used to be in really easily recognised areas that were using that constantly had ways of getting easy feedback from really kind of switched on people in terms of giving that their opinion about the care received. And now we're finding we're actually getting really fantastic feedback from areas that would not normally be kind of giving us feedback and do more of a targeted approach, and their feedback has been so powerful in terms of how we've made consistent improvements to services and the care that's given, and actually in terms of people reflecting on their behaviours, attitudes and behaviours as well, because there's some common themes about, and we think, as you're saying, our choice of language that we use, we're constantly using abbreviations, we make things very, very difficult for people to understand. So if we can quickly get that live, it's almost like live feedback in the moment that's kind of captured, and we can act on it. And it also stops that escalation to more formal complaints, because you can do things at a local level as well. I'm seeing really, really good results as well in terms of getting feedback from people with learning disabilities in terms of using a different kind of structure to the way that they can respond through pictures and things like that as well, so that all their views can be captured and engaged as well. So really, really good. Fantastic that you're actually looking at exploring that for social care services as well. It really is very powerful. So thank you.
That's good. Ellen, can I ask you the improved use of care opinion? You know, do we know why that is? Is it something that we did, or is it just it's been?
I think we're constantly promoting it and saying, please give us your feedback, any opportunity you can have, the bad and the good. So it's really, I have to say that over the last wee while, in terms of supporting and motivating our staff, receiving positive feedback is so powerful as well, in terms of supporting our teams that are really at the sharp end of things as well. But again, balance that out with some of the things that we're not doing so well. So it's that constant improvement and quality cycle, and it's just having it in our day-to-day language and saying to people, please use it, please do it, write in our comments, we want to hear from you. It's really, really important. So that's what's happening.
Good stuff. That's good to hear. Margot.
Right. Sorry,
Yeah.
I was trying, but I think it's a Teams moment I had there. And I can't really improve on what Ellen has just been saying, except to sort of commend again the success of getting all this done, because it's something that we've been trying to do as patient representatives, I think, for years, and finding it very difficult to get people across a sort of wide section of society to be involved. And this is a kind of target audience which you've met, and it'll roll out, I think, in other areas. And it was really just to look at care opinion, which again I've been signposting people to for years. And I know at another meeting I said I felt it quite often served a very valuable function in stopping people short of the complaints process, because they were getting answers which they had failed to receive in other areas. But care opinion, I think, is a tremendous asset in bridging the sort of gap between people and the role that they can play in this scenario.
No, thanks for that, and thanks for your efforts in encouraging people to use care opinion. As we're just heard from Ellen, it seems to be taking off, which is great. Suzanne?
Yeah, Thank you, Chair. It was just really to thank Leslie and Jennifer and all the partners that have been involved in the process to get us to where we have. I mean, I think being involved in some of the sort of periphery of those discussions, I think they've been really committed, they've been very enthusiastic, and they've been really sort of creative and sort of been really around the range of opportunities that would be there and sort of encouraging that support. And I think it's been particularly timely just now as we're about to review the strategic plan and the importance of seeking views from people who receive our services. We've got a number of significant service redesign options, so there's lots of opportunities to make sure we incorporate the voice of people who are using services and their carers there. And I think it's also an important mechanism to support our existing strategic planning group and our IJB representatives as well. So I think it's been a really timely piece of work, and just to thank everyone involved.
No, thanks for that, Suzanne. I'm certainly getting the impression it's been a great bit of work and it's been very well received. And hopefully Sarah's going to corroborate that. Sarah?
I am, Chair. I most certainly am. It's great stuff, and I think everybody before me has appropriately commended this, but no but intended, that just sneaked in there. What we know this really important work requires is that real constant gardening. It needs constant tending to. You know, you really need to be able to have the capacity and the resource to be able to show you're nurturing all of that throughout. It's never a one and done. And you know, I think Leslie's report goes some way to recognise that. But I suppose, Chair, just wanted to kind of reinforce the fact that this is not the start of a journey. There's been, you know, this has been ongoing in practice and consideration and strategy from the Health and Social Care Partnership since inception, but it really does need that constant support from us and that continued effort from partners. Good to see as well the recognition of staff training, because it isn't just about working alongside our partners and communities to help support them to understand how they can contribute and get involved, but also what we all bring to that and how we can best support those relationships. So just a comment from me, Leslie, to consider linkage with our trauma champions and really think about what they're setting out to put in place right across our joint workforces, which really is around that trauma informed, that responsive workforce, because a really good, better enriched knowledge of how to work with people who are impacted by trauma allows for those really, really good representative activities to feel properly collaborative and equal. So there's an opportunity, I think, to be able to bring some of this together. So it's always good when we get an opportunity to align those planets. So thank you, Chair.
No, that's a really good point about linking in with the trauma champions and those that are experienced in managing that. That's really good. So hopefully we can take that forward as well. Thanks very much. Any other questions, comments, or observations for Leslie? No, Leslie, thanks very much. Good report, and again prompted a really good discussion there. So thank you.
Great. Thank you.
So we're moving on to point 9, which is HSCP complaints and feedback performance report. Is that back to you, Gordon?
Yes, it's going to be a double team here. I'm joined with Amanda.
Oh, Amanda, welcome. You've just popped on the screen as well.
Yes.
Good morning, everybody.
Morning.
I'm very pleased you could join us, Amanda. I was sitting there thinking, ooh.
Would never let you down. Would
Thank
never
you.
let you down.
So, Chair, I'll go over the social work adult services part of the report, and Mandy will deal with the NHS part of it. 3 quick points I think I should make regarding the social work adult services part. First, if you go to table 4.4, the table at 1 at 4.4, and the bottom line of that on stage 1 report complaints, you can see that there has been a tailing off in the performance over the last 3 quarters. Now, when you go to the previous year in the table below, you'll see that actually there's been a substantial improvement year on year from 56% response within compliance timescales to 77%. What happened was about 15 months ago, we did a piece of work with the teams about complaints, about complaint responses, and we saw that immediate improvement that you can see up to 78% in Q1 of this year, 82%. Unfortunately, as I say, that is starting to slip again. So understandably, we've had a lot of challenges over the winter months, but we need to focus on that again. We need to ensure that that doesn't slip back to where it was in previous years and get those numbers back up into the 80s and above, hopefully. So there's a piece of work that we need to do with frontline managers around that to try and ensure that, you know, we embed the improvements that we've made across 21-22 for the year ahead and see what we can do to support them to ensure that the compliance is within timescales at a sufficiently high level. So that was points 1 and 2. Actually, there's an improvement year on year, but there's been a drop off in the last few quarters. The other part was to look at 4.6 in chart 1, and that's about the nature of the complaints. I had hoped to be able to present to you more detail about the sort of complaints that were coming in social work adult services. You'll see there that there has been a reduction in the number of complaints upheld, and there's a new category, complaints resolved. But that doesn't tell us enough. We need to have more detail about that. Unfortunately, the complaint system that we use within the Falkirk Council, Social Work Adult Services, the Falkirk Council complaints system, we need to go into individual complaints and draw that information out, and there just hasn't been time to pull that together to give you a detailed report. So I can report that, you know, the largest category was staff conduct. That really covers everything from people not being happy with the outcome of an assessment, which isn't down to the behaviour of the staff, to potentially staff not getting back to an individual in a timely fashion, which could well be an issue to do with the actual conduct of the staff. So I hope to be able to provide more detail on the complaints in the next report that we bring forward. Happy to answer any questions at the end. I think pass over to Mandy now for the NHS part of the report.
No problem. Thanks for that, Gordon. Just so if we start at 4.1, it's been identified, obviously within NHS we use a rolling figure, so going forward our report will come in quarters to be in line with the social work side of business. So for between April and March this year, the partnerships received a total of 23 complaints and an end of year performance at 82.6. But I did dig a bit deeper for you. So Q4, they received 7 complaints in total with a 100% response rate. So well done. That was really amazing. The performance, there still seems to be stage 1 still getting used well within the partnership. So out of the whole of last year, 8 complaints were dealt with at stage 1 and 15 at stage 2. Stage 2 performance was good at 73.3 for the overall year. The themes for between April to March, the top theme remains clinical treatment at 13, then staff attitude and behaviour, and then waiting time for appointment. I think it's important to let you know that as of the 1st of April, we have a change in our categories within Safeguard. I had taken the opportunity to take part in a national project once the complaints procedure changed between the national teams and the SPSO, where we could streamline all the categories, because the categories that we had been reporting on previously had been in place from ISD, but we're not reporting to them anymore. So we've completely streamlined. We've added in new categories. So hopefully we'll get to have a bit more meaningful information with regards to care and treatment for you. So you might see some changes in the report going forward. The departments with it for the Q4 was District Nursing, Ward 1 in Bowness, Woodlands and Unit 5 at Falkirk. For Q4, there's been no complaints received from the Ombudsman, and for the whole of last year, 3 complaints were taken to the Ombudsman, but actually none of them progressed to full investigation, which is amazing. That means the Ombudsman are absolutely satisfied with the information that we've provided them in our final response. And that's me for health, unless there's any questions.
Thanks, Amanda. Thanks, Gordon. And I just my own experience of these things in terms of the fall off it. Sometimes you just have to keep going back and reminding folk to, you know, to progress these things. It just becomes a constant battle. I see Elaine's got her hand up. Elaine.
Thank you, Chair. Just for a bit of context for the committee, my previous role in the NHS was working with Amanda and the team. I was the head of service. So that brings a kind of unique skill set with me, and actually in terms of that, what you're needing, Gordon, that'll be me that'll be doing that session. There is a bit of work coming, and it's around person-centred learning and development session we'll be doing. So I'll be coming to your place shortly. I think the other thing is it's really interesting when you step back from an area that you're really close to, you see things a bit differently and a bit clearer. And Monday, I think it would be really good for us to see the outcomes. We can see in SWAS we've got the outcomes for complaints, but it'd be good to see that in the health sector. And you guys have that in your big report anyway, so it's just pulling it over.
Absolutely, absolutely. And I've got the outcomes here for Q4 if you would like them. So the 3 stage 1s for Q4 were not upheld, and the 3 of the stage 2s were not upheld, and only 1 of your stage 2s was partly upheld for Q4. So absolutely happy to include that in the next report.
I think it gives it really good context.
Absolutely.
That position. Thank you.
Yep. Thanks.
Thanks, Elaine. Any other questions for either Amanda or Gordon? No? Thanks very much, both of you, for your joint presentation there.
Thanks, guys.
Thank you. So we will move on to agenda item 10, which is the overview of local oversight arrangements. And I think that's you, Suzanne.
Thank you, Chair. The report presented to committee provides an overview of the local oversight arrangements that are relevant to the Health and Social Care Partnership. And this is a standing agenda item report for the committee and is intended to provide assurance on a range of arrangements that are in place. So each section of the report provides an update on the various groups that are in place. Section 4 notes an update from the Public Protection Chief Officers Group, and we've included a summary of the adult support and protection performance, and that's taken from the fortnightly data submissions to the Scottish Government, and that information is at 4.11. This data is also monitored by the Adult Protection Committee, and an update of the work of the Adult Protection Committee and its 4 subgroups is noted at section 5 of the report. Just to draw your attention to information that's presented at 5.12 of the report, which notes the work that's been done to deliver a new training for the trainers course for care homes and to support the implementation of adult support and protection champions within each care home. NHS Forth Valley clinical governance updates are outlined in the report at section 7. And care home assurance work is detailed within section 8, with continued progress continuing to be made on completed reviews and the chart team's support to care homes. An update on the community health and care oversight groups included at section 7. So in summary, the report sets out, like I say, the overview arrangements, and committees asked to consider and comment on the report, and hopefully if there are any questions, my colleagues involved in those groups will be able to answer those. Thank you.
Thanks, Suzanne. Any questions for Suzanne or anyone else who's has mentioned this report that could assist with any of the background information? No, going once, going twice, going off lightly there, Suzanne. Okay, so we'll move on to item 11, which is the hospital-acquired infection performance report. Pass you over to Jonathan.
Okay, thank you, Stephen. So yes, Morning, everyone. This is the quarterly report for January to March this year. So I'll just give you a quick overview of some of the things that's been going on over the quarter. So just give an update on COVID at the moment, the way we are at the moment. Back early in January, we saw our first peaks of inpatient admissions with COVID. This was the advent of the Omicron variant, as you're aware, or if you can cast your minds back in mid-December, that variant was discovered in Scotland, and for whatever reason, Forth Valley always seems to lag behind a lot of Scotland in terms of when we feel the, if you like, the pinch from these variants. And so it kind of hit us at the start of January, where we had an increase in outbreaks and also inpatient admissions. After a while, that seemed to decrease, and then we had a second peak with the Omicron subvariant that actually came out, and so this was perhaps even worse than the first peak we had this quarter. We had over 100 inpatients at one point in March. So, but since then, numbers have declined, and now we're sitting around about 18 inpatients with COVID. Interestingly enough, now most of the infections that we're having are often very mild now and or asymptomatic. So things have certainly changed from what we've seen in the previous past, in terms of mortality and associated with the disease, which is good. Just to give you an update as well, Scottish Government are keen for health boards now to sort of step down from the current winter respiratory pathways that are implemented across Scotland, and a department letter was sent out to boards last week instructing boards to do this, and we've got a timescale of up until July to implement these, based on the current risks in individual boards. So they're not being very prescriptive, which is good, which helps each board then step down in its own time and when it's safe to do so. So some of the things that are involved, like the physical distancing, from 2 meters down to 1, and also like the day 5 admission screens and things like that. So there's a lot of emphasis on those kind of things at the moment. These changes are not yet applied to care homes. Public Health Scotland, I believe, are in reviewing things at the moment, but I don't think there are any plans at the moment that this would be applied to care homes. So at the moment. Moving on to the support in terms of, as we're talking about care homes, in terms of the infection control support, we have 2 staff, full-time staff, working with the care assurance team that are providing support to care homes. At the oversight group meeting yesterday, it was quite clear that the number of outbreaks in care homes have decreased quite significantly at the moment, which has enabled the care assurance team, with support of my 2 staff members with that team, to be more proactive in terms of rolling out like the gold standards to care homes. And also now, last week, the new IPC standards were published. So these are the standards that apply to both now health and social care, and the care inspector actually leading this in terms for the care homes. I believe there's a grace period of up to September before it's expected for care homes to be fully implemented with this. I think there'll be some challenges, if I'm being honest. I think, the standard, we've been working to standards within the hospital settings now for upwards of 15 years or so. So we're very much averse to working within the confines of these specific IPC standards. So, but I think, there is some challenges there, I would imagine. But I believe the care assurance team will be providing support in addition to the care inspectorate to the care homes as well. And I understand the care inspector, who will be inspecting them to these standards as well come September, is hosting a few webinars over the next coming months to help care homes implement these standards as well. So moving on to our annual operating plan targets, we have 3 targets that we have to been set by government. So these are E. coli bacteremia targets, Staph aureus bacteremia targets, and Clostridium difficile infections. Now, all these targets that were set were due to be completed by March of this year. For us, for Forth Valley, we achieved our Clostridium difficile target, and our Staph aureus bacteremia targets, we were 0.1 of a rate out, but we would probably have achieved that target. Our E. coli's bacteremias, as I've explained in the past, we've had a number of challenges around that, but we were quite way off trajectory with that one. Having said all that, from a national standpoint, the targets weren't met nationally. So as a result of that, there was a proposal, as I mentioned at the time of writing, it was proposed that the targets would be extended, and last week the Chief Nursing Officer confirmed that the targets have now been extended to March 2023. So I sit on a national surveillance group in regards to these, and they are looking at the E. coli bacteremia target as a whole, because they now recognize that it's not within the gift of infection control teams to reduce the numbers, because the predominant numbers of people coming in with E. coli bacteremias are coming in from the community and associated with dehydration and lower urinary tract infections. So there is work now and a review going on about how this should be incorporated into, wider stakeholders rather than just the infection control teams to if you like, be concerned about this and act.
We've either lost Jonathan or he's playing statues with us. But I think we've.
10 reported cases.
Sorry, Jonathan, we lost you for a few minutes there. You're back.
I did. Yes, I did see. I did go a bit black on my screen, but I'm back now, so that's good.
Okay.
Lucky you, eh? Right. So our Staph aureus bacteremias, yes, as I said, we had a reduction this quarter. In terms of Falkirk and Community Hospital and Bowness hospitals, there were no reported Staph aureus bacteremias, which is good. Our device-associated bacteremias, so these are infections that are associated with people who've got like urinary catheters and so on. Again, it's remained relatively stable this quarter, although we've seen a reduction in our hospital total numbers overall. In terms of Falkirk and Bowness, there were no reported cases. Our E. coli bacteremias, like I said, this is under review, so I'll keep you updated. But again, our numbers remain relatively stable, although we have seen a reduction in our hospital-acquired infections, which is encouraging. And again, Falkirk and Bowness community hospitals, we had no reported cases, which is good. Clostridium difficile infections, again, our numbers are very low here, and remain stable in the last quarter. And again, Falkirk and Bowness did not have any reported cases. Moving on to the estate and cleaning compliances. Now, this is data that's submitted by our domestic teams nationally and are then reported. So in terms of Bowness, numbers remain relatively stable. We're still in the green there. Falkirk Community Hospital remains a little bit lower than we would like at 86 compared to 89 the previous quarter. But we're hoping that will change over the next coming quarter. In terms of incidents and outbreaks, we had one reported outbreak across the area, and that was in Bowness Ward 2, where we had 10 patients confirmed as positive. Historically, we've seen certainly over the last 6 to 8 months, from a national perspective, the most common areas where they've seen outbreaks occur due to COVID are in care of the elderly areas and mental health areas. So this fits in quite nicely with what we're seeing as well. So yeah, so we only had the one outbreak. We haven't, just to let you know, that we have no current outbreaks at all across the hospital sites at all, and we haven't done since April. So we're quite encouraged by that. But that's the report. So I'd be happy to take any questions.
Thanks, Jonathan. Informative as ever. And I'm not going to put the spot in here specifically, but good news due COVID. But I mean, where do you think we're going with that? I mean, is that the $64,000 question?
It is, but we're hopeful. I mean, we were anticipating a peak another surge of inpatient admissions after the step down in April about not wearing face masks in public areas and things like that, out with the hospital settings. And we didn't, and it usually takes about 2 to 3 weeks for that to happen, from what we've seen in the past. And there was no peak from it. So we were quite encouraged by that. So, well, hopefully, fingers crossed that we're heading in that right direction. And I do believe we are, actually. I do think so.
No, that'd be good, because we do need a bit of respite and then start to return to some form of normality and catch up with all the things that we need to be catching up with. So thanks for that. Any other questions, observations? Elaine, yeah, your hand's up, and then Margot. Elaine.
Thank you, Chair. Thank you for the report, Jonathan. Just a comment on the COVID outbreak at Bo'ness 2. And I just wanted to kind of share that was a difficult situation, and that it was a real opportunity for us to work together as a kind of team again in that space. And that for me, that the geography and the layout of Bo'ness Unit 2, for anyone that's been there, it makes it really tricky to look after patients really safely when there's any kind of infection issue, be it COVID or D&V, whatever. It makes it really, really tricky because the patients are so complex in their presentations. It makes it really, really tricky. But I think for me, for that assurance position, I felt really assured around the care and treatment that patients were getting, and the infection control support that we were getting in terms of keeping us right. And I just wanted to kind of share that with the committee, that was a real troubled time for us, because we were really worried about the patients in there, and their families were really worried. But it had a really good outcome in terms of how we managed it. Thank you.
Thanks for that, Elaine, and I'm glad it was well managed and it was a good outcome for all. Margot.
Right, I think you're quite right to look to the future. My comment, and it is just a comment, is that it's very sad that now we're trying to investigate what happened in care homes during the pandemic, and not to assign blame, but I hope that for the future more focus can be on care homes and practice there, but as far as healthcare acquired infections concerned.
Yeah, thanks for that, Margaret. I think obviously appropriate to look back and learn from what happened, because I'm sure this won't be the last time we'll have to deal with something of this magnitude, and hopefully we'll have learned the lessons. Any other questions, comments, observations for Jonathan? No, Margot, you want to come back in?
No, sorry,
no,
getting rid of myself.
No worries. Jonathan, thanks again. Thanks for your time this morning. So that we move on to the final, and this is for a decision, which I'm sure is for the approval of the committee, and this is the Annual Assurance Statement 21-22 and the CCG Business report by the Senior Service Manager. Who is going to cover this for us?
That's myself, Stephen. Thank you very much.
Cheers, Suzanne. Thank you all.
So the report presents the draft annual assurance statement for the committee, and as you've noted, subject to your approval today, it will be presented to the IJB in September, and that will be part of a suite of annual assurance statements that we do for the Audit Committee, the Joint Staff Forum and Clinical Care Governance Committee. The report also notes the clinical care governance membership in terms of reference that need to be reviewed, and the work that's sort of underway or planned around this. So the committee will be familiar with the requirement to prepare an annual assurance statement, and that came from a recommendation of an internal audit report that we had in 2019. And this is the third annual statement that we've provided, and that's attached to Appendix 1. So it sets out the attendance, meeting dates and the business of the Clinical Care Governance Committee from April 2021 to March 22. In relation to the membership, due to the local government elections, a new council voting representative will be needed to be appointed, and that also takes into account the need to then look at the chair and the vice chair arrangements, and they'll need to be approved by the IJB. So we're currently working on a report to the IJB in June that will set out those requirements for the board's consideration. Like I say, the report also notes that work needs to be done to review the terms of reference, and I think linked to that, because they are very closely linked, is also the clinical care governance framework, and an update will be provided to the next meeting for some consideration comment. So in conclusion, the committee is asked to approve the report recommendations at 2.1 to 2.4, and I'm happy to take any questions. Thank you.
Thanks, Suzanne. Any questions, observations and comments on that report? No, we're all happy with the content of it and happy to approve. Thanks very much, folks. Well, that's the end of today's business. So thanks for your attendance, your efforts this morning. I have the next date in my diary as Friday the 26th of August. I think that's the, hopefully maybe even be in person by then, but we'll wait and see. Okay, well thanks very much. Enjoy the rest of your day and enjoy your weekend if you're not working. Cheers.